Hey everybody, what's going on? Welcome back to Crashcart Nursing. I'm Nick McAllister and I'm here with Courtney Wong. Today we're talking about all kinds of fun stuff, maybe not so fun stuff depending on where your brain is at. Because today we're going to dive deep into dosage calculation. So, math is always something that is challenging. It is something that nursing students seem to struggle with quite collectively. There's always a few who go through and you can tell that math was a strong suit, but the majority of classes that I've seen in education always seem to struggle with these different things, and they're high yield for NCLEX. They're important topics to talk about, and really they're life and death for our patients. So we want to make sure that you do a good job at your math, the dosage calculation, making sure that doses that are going to patients are accurate, because at the end of the day, if you do this wrong, it's more than just making a med error and filling out a report. You could literally overdose somebody, underdose somebody, and make somebody's already bad day even worse. It could be the worst day of their life, and it could become the worst day of your life. As a nurse, we always talk about wanting to protect your license. We talk about how important it is to be accurate in our clinical judgment. But a big part of our nursing practice is making sure we're accurate in medication administration. So fortunately, we have Courtney Wong here, who is a math wizard, and students on our campus have actually called going deep. We've described her as a verb of doing a
Yeah.
Courtney or pulling a Courtney
Yeah.
because she goes
Courtneying
super
out.
deep, Courtneying out, however you want to use that. But today, I hope that you gain something from this. Maybe it's a refresher for you. Maybe you're like, okay, I don't need this. I know how to do my dosage calculation. Remember, there might always be new tricks, though, that might help you in your practice. So watch the video. If you need to speed it up, go ahead and speed it up. If you need to pause, go ahead and pause. If you need to take screenshots, whatever. But I would encourage you with math. There is magic that happens. My students know this. I say this all the time. There is magic that happens when we write stuff down, pen to paper. It's amazing. It is actually a neuroscience tip to write things down. And I just feel like math in your head is great, but there's just a certain point where you can't do it in your head. You gotta dive down deep and write it down. I always watch my daughter, she's 12, struggle with math because she'll sit there and she's trying to be a mental ninja and she's very good at it, but she won't write stuff down. And then finally she'll cave and grab a piece of paper and start writing stuff down. I'm like, see how much easier it is when you like show your work, write it out. Like I feel like kind of a hypocrite because my whole life growing up, I was like, screw that. I don't
Yeah.
want to write it down either. But here
I
I am, like,
am
write
very
it down.
much a pen to paper person.
I think it's the only way
Even
to do math. Like I'm like,
I
you
mean,
can't.
this is so like I'm even like let me just double check that, 3 plus 4 equals 7. Like, let me just double check. But that's me. I don't know.
We had a guy that I used to work with. He'd always call it doing a discount double check,
Yeah.
like the
Yeah.
insurance ads. Hey, let's give a little discount double check here on this med math. I think
Yeah.
it's a great thing to do. So anyway, we're going to get into it. So pull a pen and paper out, get ready, and let's go.
So we're going to start with conversions. Now, here's the reason conversions are important, right? Is because when a math problem is easy, you don't have to convert, but a lot of the times you do, whether it's your weight or a med dose, right? Or fluids when you start getting into like liters per hour and things like that. So, but it's also important because we have measurements for weight, right? We have measurements for fluids and we have measurements for length. And so, we don't measure wounds in inches, right? We measure wounds in centimeters, in millimeters, and things like that. So, but let's just kind of start off with the two different types of measurements that we use. So the metric system is what like science and healthcare uses, and a lot of the rest of the world, right? So this is our metric system. So this is where we start to see like our grams, right? Our meters, our liters, and then Celsius. And then the reason, obviously, we have other units as part of that, but those are kind of like our base units. And that's going to be really, really important later. But the reason this is so nice is because it's very, very accurate, because everything is to get to the next like step of this ladder. Everything is a conversion of 10. So it just makes it so easy. You're literally just moving your decimal point. So for healthcare metric system, that kind of seems to throw a lot of people off, right? Especially when we start looking into like imperial and US customary into metrics. But What a lot of you might be familiar with and what's kind of used in everyday life is on this side. This is your imperial / US customary. They're very, very similar, but there are a couple differences, but we're not going to get into that. Just, I'm going to include everyone, right? And these are going to be where you see more of those common terms like pounds, ounces, cups, inches, feet, that type of thing. And this is what most of your patients here in the US are going to be familiar with. So when we're converting our metric system, so right here, these are our base units. So you see these like little green dots, right? These are our multiples of 10. Now, the reason they're green dots and not actual letters is because the green dots, we don't give a shit about, okay? So when you're in grams, so to convert grams to milligrams, right? We're going to move that decimal point 1, 2, 3, 3 spaces to the right. We're going to multiply it by 1,000, okay? Going from grams to kilograms, we're going to move it 3 spots to the left, right? So then we're going to divide by 1,000 to convert grams to kilograms. So these are kind of the jumps, right, that we're using to go to each of these. Now, with the weight-based unit, right, we're going to have a little bit larger of a scale because we obviously weigh patients, right? We use kilograms to weigh patients. But we go all the way down to like micrograms for dosage calc. So it's really important to know all of those. Now with fluid, right, our base unit is this liter right here. Now we also use milliliters, but we're not really going to use like microliters, right, in healthcare. So we're going to kind of focus more on this liter to milliliters conversion. So really knowing this is to go from a liter to milliliters, same as our grams, we're going to move our decimal points, right, over 3 and multiply it by 1,000. And then vice versa, if we're going from milliliters to liters, we're going to divide it by 1,000. Now, meters, this is where it gets just a little bit different, right? Because we can convert. So meters is our base unit, and we can convert, right, that multiplying by 1,000 to get to millimeters, which we have all heard of millimeters, right? But we also use centimeters. So where this one gets a little tricky is we don't just kind of hop those 3 decimal points. We actually can multiply by 100 to go from millimeters to centimeters. And then if we multiply by another 10, then we can go from centimeters to millimeters. So this can be a little confusing at first just because you are moving that decimal point over like a lot. But that's the cool part about the metric system, right? Is that it's all done by tens. So another important thing that I want to kind of add here is with this idea of like trailing and leading zeros. So when we're moving the decimal point, right? If there is nothing before the decimal point, we use what's called a leading zero, right? So we wouldn't write 0.125, right? We would not, that's not a good thing to do because someone might miss that decimal point, right? Someone might mistake it for something else. It's just a larger kind of like margin for error. So instead, we would use 0.125. That's going to be your leading zero. Now, trailing zeros, right? We try not to use those, right? Because writing 125 0, right? Someone might mistake that as a comma or they might miss it, right? Depending on where it is. So we never want to use these ever. So instead of writing 125.0, you would just write 125. That's really important just to kind of note.
And this precision matters a lot when we're doing these dosage calculations. Like I've seen so many times where, and even just in passerby conversations where people will say stuff where they'll say like 0.8. And that's a problem because it can get misinterpreted, especially if written. So we just have to make sure we have that leading zero. And so you'll hear people be precise and say 0.8. And it's at first it feels weird, but that communication is just a standard way of communicating so that we don't make mistakes. because an extra zero or an absence of a zero can be the difference between over or underdosing somebody.
Right. Exactly. So, yeah, just keep that in mind. And then, so let's kind of practice real quick, just filling in these first little lines of conversions. So, using our little dots, right? 1 kilogram is going to be equal to 1,000 grams, right? 1 gram is going to be equal to 1,000 milligrams. Are we seeing a pattern? 1 milligram is going to be equal to 1,000 micrograms. You might also hear that called mics. I've said that, just not thinking about it a couple times. So
Yeah.
if you hear that, that's what that means. It's just micrograms. And then 1 liter, and then 1 meter equals 1,000 millimeters. So just so you can kind of see like how almost systematic this is, it like tickles my brain just the right way. But some other noteworthy conversions, right? Okay. And these are going to fall more kind of into that imperial US customary, like household type measurements. So your 1 tablespoon, right, is equivalent to 3 teaspoons. 2 tablespoons is equivalent to 1 fluid ounce. 1 tablespoon is equal to 15 mils. 1 teaspoon equals 5 mils. And then 1 fluid ounce, that's the FL.OZ dot, is equal to 30 mils. So you can kind of see the relationship between these, right? Of if 1 fluid ounce equals this 30 mils and 1 fluid ounce is equal to 2 tablespoons, then when you're doing converting in real life, then you can kind of deduce, right, that 1 tablespoon is 15 mils. One trick that I always like to teach students is to try to connect these things. That way, memorizing everything doesn't seem quite as daunting. Like if you can reason your way down, right, by learning 2/3 of them instead of all of them, then
Yeah.
sometimes that can be helpful for people.
For me, when I was learning dosage calculation, I remember learning the, 3 teaspoons equals a tablespoon and really
Mm-hmm.
actually putting that into practice when my kids asked for French toast or something and the recipe called for a tablespoon of something and I didn't have
Yeah.
it. And I'm like, oh, sweet. I'm like, three teaspoons equals a tablespoon. Is that real?
Yes.
And I'm like,
Yeah.
it is real. It does work that way. You can do it. If you don't have all
Yeah.
your teaspoons or tablespoons laying around because your kids lost them or threw them away like they do,
Oh, shit, I didn't even think about that. That's so
your
true.
kids are throwing away your spoons. I'm just saying, it's happening.
'Cause people who bake are gonna have a really good time with this because, like, a lot of the
It's
times
pretty
if you
cool.
bake, you use the metric system instead, but and then the other kind of notable ones is 1 pound, right, is equal to 2.2 kilograms.
Kilograms. Well,
And then
and that's a very big, important one. You need to know that one, like,
big,
for
big important
every
one.
problem, I swear, it's always you would
Star
think that they're
that.
just gonna give you the weight in kilos, but no, they're gonna give you the weight in pounds. You're gonna have to convert before you even
Mhm.
get to the problem.
Right. And then another one that can be kind of important is that we've kind of like started to move towards using just mils, but you might hear, especially people who have been nurses for a little bit, still use cc. 1 mil is literally equal to 1 cc. I am also guilty of using those kind of interchangeably. So if you hear that, they're the same thing. Just replace it with mil. Um,
Which stands for a cubic centimeter.
yes. So let's get down into the nitty gritty of it. So this is going to be for our kind of like our oral meds, our meds that we draw up, right? Um, and so we have 3 different formulas that we can use. So there's formula method, there is proportion method, and then there's dimensional analysis. Now, each one, people tend to find one and they really, really like it, and then they don't deviate from that. Absolute disclaimer. I am a formula method gal. I spite taught myself dimensional analysis for this. So the questions are going to be really, really easy so that I can explain it. But I'm a formula method. So the cool thing about the formulas is even though they're all done a little bit differently, they all need the exact same thing. So you have supply, demand, and have, and all of these formulas are set up with those 3. So for supply, or for the S, that is our supply we have on hand, right? So what does it come in? Is your unit that you're pulling what you have from a pill? Is it 1 pill? Is it 2 pills? Is it 5 mils? Is it 100 mils? Like, it's whatever you have on hand, right? Your supply that this is coming out of.
And importantly, it's gonna have your milligrams and milliliters if it's fluid. So milliliters
Yes.
are fluid that it is mixed up in. So if you have a dosage of medication that's like 4 milligrams of medicine in 10 milliliters of saline, the milligrams is the amount of powder that got mixed into the solution. It's the amount of the actual
Right.
medication in the liquid. So we
Right.
need to be
Extra careful
extra careful in
on that.
making sure that we're converting that correctly, but we're going to get more into that.
Yeah. And then D is going to be the dose that we are looking for. So what's our desired dose? This comes from your doctor's order, and we'll look at that a little bit because we do have like some example problems for this, but this is what did the doctor order? Desired, doctor ordered, right? And then our H is going to be what do we have on hand? So kind of what Nick was saying about, like, if it's, 100 milligrams in 5 mils, right? The 100 milligrams is what we have, and it's supplied to us in the 5 mils. But we'll kind of take a look at some of that. So all of these are going to be color coded. So when you go to break down these questions and use these formulas, if you just look and kind of narrow everything down, find your supply, your demand, and your have, right? You can solve it and you just plug it in to these formulas. So it does make it a little bit easier to kind of break it down. So for the formula, we have, because we're solving for X equals supply times desired over have, right? For the proportions method, we have supply over have is equal to X over desired. And with this one, we actually cross multiply. So this is the formula where we're going to multiply these two, right, by these two. People who like algebra really, really love this version because that's when you did that, right? It was in algebra. And then dimensional analysis. Now, this one is different in the sense that you add your conversion factors, right, into the same formula. So we'll look a little bit more into that. But once you find your supplied, your desire, and your have, you're going to set it up kind of in like this little, I don't want to say tic-tac-toe, but like a little cross method. And you're going to put your supply here, your have here, and your desired over here. So before we look into this too, one of the things I also tell my students is there are 2 things you should be asking yourself every time you read a question. This does not just include math, but it is very helpful in math, but it's also helpful for other nursing questions. Is the first thing you want to make sure that you know is, what is the question asking me? Right? Because sometimes they give you all of this information and it's really easy, especially if you like get test anxiety and things like that, to kind of get thrown off by looking at it as a whole, right? So the first thing I would encourage you to do is, what is the question asking me, right? The second thing, what do I even need in this question? I am not above reading a question, and if I'm able to write on the test, I will actually just cross it out if I don't need it, to try to lower the amount of information that I'm looking at. And then once you do that, then you can start working towards your supply, your demand, your desired, and your have. So let's kind of see this in
The
action.
thing is too, is that how many times do students look at a question and maybe the answer is right there in the question and they actually don't have to do math, but they go through this whole process of doing this crazy ass math problem
Right.
that they didn't even need. Maybe it's like, here's what you have. And it's like, what's the concentration? And they've just done this whole math problem trying to figure it out for the person who weighs this many kilograms. And you went way deeper than you needed to go because it just asks a concentration
Right.
question, like how many per mil? And you're like, oh,
Yeah. That, and another big one too, and is it'll ask you like, oh, this patient can get this medication like QID, right? How many, like, what's the max dose that they can do? And they'll answer with just like the single dose instead of like all 4 doses combined. So let's take a look at like a really easy order, right? So your order is for Tylenol, 650 milligrams PO daily, right? Pharmacy supplies you 650 milligrams per tablet, right? So when we break this down into the supply, right, is going to be this one tablet, right? Because this is what we have on like as our unit that we're able to pull from, right? So it's per tablet. Our desired, right? Our desired we get from the doctor's orders is going to be the 650 milligrams. And then what we have in our supply is 650 milligrams. So that's where we got each of these numbers. Now, when you plug these into the different formulas, so screenshot these if you would like, but I wrote all of the formulas up at the top. So when we plug these in, let's start with the formula method. So X equals supply times desired over half. So I didn't trail down the X, but just know that this equal sign is just bringing it down. So 1 tab, right, times 650 milligrams divided by 650 milligrams. Now, the reason you see this little red line here is because if we're dividing by the same unit, and this is where a lot of conversion comes into play, but if we are dividing by the same unit, we can just get rid of it because we don't care about it. So when we get rid of it, when we can cancel it out, we're left with 1 tab times 650 divided by 650, right? Which would leave us with 1 tab times 1. So our answer is 1 tablet, right? And then on dimensional analysis, so our X equals kind of this little cross pattern, right? Supply over have, and then the desired. So let's plug everything in. So we have our 1 tab over here. We have our 650 milligrams over here, and we have our 650 milligrams over here. So with dimensional analysis, all this little cross pattern is meaning is everything in the same line, right? So any numbers in this line or any numbers in this line, we're going to multiply them together once we cancel out as many units as we can. And then everything that is above here, we're going to divide by whatever is down here. So when we plug in our numbers, right, because this milligram is over this milligram, right, because it's above this line, we can just cancel them out. That's what those red lines are. So we can get rid of these milligrams because if we can cancel them out, we don't care about them, right? It's just a lot to look at. So when you break that down, it equals 1 tab times 650, right? Because remember, this little guy right here just means times. And then because it's over this 650, we're going to divide it by 650. And we get 1 tab, right? Now, proportions is a little bit more algebra based. And so we have our supply over have equals our X, which is what we're solving for, over desired. So we'll plug everything in, right? And then we cross multiply. When we cross multiply, we're going to get 1 tab times 650 milligrams equals X times 650 milligrams. Oh, but look, because they're on opposite sides of the equal sign, we know we don't need those, right? Because they're the same. We don't care about them. So then we're left with 1 tab times 650 equals 650x, right? And then when we multiply these together, it gives us 650 tabs. So then we can just divide 650 tabs by 650 because these will cancel each other out, and then you're left with X equals 1 tab. So choose your own adventure, but really these all boil down to finding your supplied, your desired, and your have. Just sometimes that looks a little bit different.
Now, obviously, I know that there's going to be somebody who's going to come in the comments and be like, well, I could see at the beginning it's 650 milligram tablet, PO daily. and you have available 650 milligram tablet. They're the same. It's one. Did I really need to do a math problem? The answer is no. Obviously, we don't need to do a math problem for this. The point is to show you that all dosage calculation is really this simple. It is really just taking what is ordered, what do you have on hand, and making those two match. And a lot of times students really get off in the weeds about this, and they're like, oh my God, it's math, it's hard, I can't do this. And it's really is just this simple where we're just matching up the two things. What's ordered?
Exactly.
What do we have? How do I make a match so that I can give the right dose of medication? And a lot of times we just, I feel like if your only med administration history is at being at home and like taking some ibuprofen, being like, well, I take 600 milligrams of ibuprofen, so I know that that's I take 3 ibuprofen or whatever at a time.
Yeah.
Like, that's fine. If that's all you're used to, you are essentially doing your own dosage calculation at home. You have ordered yourself 600 milligrams of ibuprofen. They come in 200 milligram tablets, and you're matching it up with your own order that you gave yourself, right? That is all the dosage calculation is. So we can take some mystery out of it. And this is not challenging math. It is basic math. We can just easily get confused. And a lot of times we have to do math problems after critical situations. So our brain is already going at a million miles an hour. Stuff is chaotic. We got stress response happening. Cortisol is being released, epinephrine, all the things, all these, neurotransmitters firing like crazy because we're stressed. And then we have to do a math problem, and it feels like adding insult to injury. It's like, I am already not at my best, maybe in that moment. And now I have to do math, and that just messes some of us up. So we want to make it simple. We want to show you the simple ways with the simple ones where you're actually going through and doing a problem so that we can build on it and get more complex.
Yes, exactly. Because when you're doing, which we'll talk about this later because I was going to bring this up during this podcast. There are absolutely times you will have to sit and do med math at the nurse's station, right? We'll talk about it later. But really, ultimately, no matter how crazy intense the problem is, once you break it down, this is all it is. This is all it is. And sometimes it just requires a couple more steps, but Nick and I like to use the term demystify things in the nursing profession, right? We're going to demystify math today because math's amazing. I love math. Shocker. So now let's get into something that's slightly more complicated, right? But again, we're just plugging in numbers into a formula. Okay. That's all we're doing. So for drip rates, sometimes you'll see this converted into GTT or GTTS, right? So drop or drops. If you don't have a pump, right? Sometimes you have to dose and set your rate based off of these drops. I'm sure, Nick, you probably use this a lot more in the ED than I did.
Surprisingly,
I don't know.
no, because we actually have there's a couple ways. So
tubing
we have the tubing that has the thing on it. If you're going certain mils per hour, you can just crank the wheel and put it on however many drips per minute. But in a pinch, it is good to know how to do this. I've done this actually on MedSearch before, where we had to count it.
Oh, interesting.
Yeah. But only in times of extreme duress to have to do this. I think I've done it like once or twice. It's not like it's a regular occurrence, but you want to know how to do this so that you're kind of a badass and you can make stuff happen. Even
because
when
if
don't
you're
have
like
all
the
the
one
technology.
person that knows how to do it,
It's
time
like
that you
counting
need to do it,
change or downtime charting. It's just you hope that you never have to use it, but sometimes.
But sometimes it's good to know. Yeah. So for just to make it really simple, right? We're gonna calculate these in minutes, but to kind of get everyone on the same page, just in case you're watching this and this is all brand new, right? So drip rates come from the chamber of the tubing. So when you zoom in, so this is our drip chamber, right? And you can kind of see like these little drops here. There's two different types, right? You have like the microneedle and the macroneedle drip rate tubing. And so the drips per minute is really just how many drips does it take to get a mil of fluid, right? And so these are pretty much always going to be, when you're looking at the packaging of your drip rate tubing, you're going to see it like in strips per mil. Okay. So whether it's the micro one where it's like 60 drips per mil or the macro one where it's like 10, 15, 20, like it'll tell you on the packaging that you're looking at. Right. And so we take the proportion formulas out of this. So we really only have formula method and dimensional analysis method. So the formula method is going to be your number of mils to infuse times your drop factor, right? So how many mils are we going to infuse? What is our drop factor? And remember, we get that off of our tubing, right? And the number of minutes that you're looking to infuse all of this over, right? So whatever your order says. And then your dimensional analysis method. So we set up our little cross pattern again, and it's actually, let me change this to this. So it's your drip, right, over your mill. So this is just this, okay? So your drip per your mill is just what your tubing is rated, right? Your mills to infuse, did we notice the same thing, right? We're just plugging in the same thing. And then over your minutes. So you're going to end up, right, once you cancel out your units, you're going to end up multiplying these, you're going to end up multiplying these, and then you're going to end up just dividing the whole thing. So works exactly the same way. So let's take a really, really easy problem. So we have infuse 1 liter of fluid over 2 hours. That's your order, a very basic order. What is the drip rate per minute? And we want to round to the nearest whole number. So it's like your 5 or more, raise the score, 4 or less, let it rest, right? So if we get a decimal point, we're going to round it to the nearest whole number, which means we're not going to care about the decimal point. In drips, that's pretty standard because we can't give half of a drop, right? It's not going to drip unless it's a full drip. So we're going to round it to the nearest whole number. And then our drip factor on our tubing is going to be 10 drips per mil. So in the formula method, I went ahead, because this is how I like to do mine, is I just converted it to fit into what I needed, right? So if you think back to our conversions, our 1 liter is going to equal 1,000 mils. And then our 2 hours is going to be 120 minutes because there's 60 minutes in an hour. So when we plug this in, it leaves us, the blue is going to be our first step, by the way, in each of these. So on our blue square, we have 1,000 mils times 10 drops per mil, right? All over 120 minutes. Now remember, we don't really care about these mils, right? Because they're there. So we can just cancel those out. And we're left with 10,000 drips over 120 minutes. Okay. When we divide 10,000 by 120, it gives us 83.33. But remember, we have to round to the nearest whole number. The nearest whole number is 83. But we still have our GTTs and our minutes left. So this gives us our 83 drops per minute. So that's our answer to that problem.
And I want to point out too that a lot of times these dosage calculation questions will do some extra step to this. So say this is your question where it's asking about, it's giving you the one liter of fluid over 2 hours. And then it's going to ask you a question like, how much volume have you infused after 1 hour? So all we're doing then is splitting it in half because we know that this overall, this whole amount went in 2 hours. So now we just got to cut it in half. It's just dividing it by 2. So this is where it becomes so important of like, how to calculate the drip rate. And where students end up getting stuff wrong is when they just haven't read the entirety of the question. So like I can go back and I can look at their work with them and I see that they have everything correct up until that last step because they just don't finalize it. So just before you hit submit in ATI, before you hit submit on your test in whatever, LMS that you're using, learning management system that you're using, whatever, before you hit submit on the question or turn it in, just double check, make sure, did I answer what they're fully asking for? Or maybe they'll say, they'll ask how many drops per minute that you need to be giving. And that is really the answer. And you find out that, okay, yes, I read the whole question. I answered everything that they wanted. But if you didn't, make sure you go back. And that's the only time you should be changing it. Like I tell students all the time, don't change your answers. You go with your gut. Well, in this situation, this is not a gut instinct. This is a, did I actually answer the question and give them
Yes.
what they asked for?
Yes, and that's why it's so, so, so important. That is why I stress to my students, first thing you should do is familiarize yourself with what the question is asking you, because that is exactly what happens. That's exactly what happens.
Well, and in all reality, these questions, med math questions, is like at the beginning, they feel really hard and difficult to
Mhm.
get through. By the end of your time in nursing school, these should be free questions. Like in all reality, they're free points. They're simple. Once you know how to do it, you know how to do it. And you should be answering them correct every single time. And we have students that are like, well, I should pass with a 90%. I should be able to pass with an 80% because that's still a B. And like, that's a great, math score in my head. But like, do you want the nurse that's wrong 20% of the time? I want mine to be correct about the math of the
Yes.
things that they're giving me. So these should be gimme questions, and you can be like, well, they still technically could have passed the class. You shouldn't be that hard on them. Like we have to though, because I
Yeah.
want you to be good at math. I want you to be able, and it's not just about math. This is life-saving math. This is the math that actually matters.
Right. And I always tell them too, I'm like, we had to get 100 on ours. And that was exactly what my nursing professors told me was you want to be right on your math 100% of the time because it really can hurt someone, right? It really can.
Yeah, we're not talking about some empirical thinking that's way out there or, some concept that is difficult to understand. It's like your numbers don't add up. At the end of the day, you're going to kill somebody if you don't have your math right.
Right. Right. But just to move to show you it in dimensional analysis. So now we're going to throw in those conversions, right? Because we have to, because we're looking for minutes, but what they gave us is in hours. So now this is when we start looking into dimensional analysis and we start writing everything out and plugging it into this formula, right? Because the whole point is that we're going to use these conversion factors to cancel out the units. That's really what we're looking for. So we're going to plug it in, right? I have my drips, I have my mill, right? And I got it from here. This is where I got that. So 10 drips over 1 mil. But then we have our mills to infuse. But what the question gave us is 1 liter. So we're going to plug in how much we have to infuse, but it's not in the correct unit. But we're going to fix that later. And they want it over 2 hours, but we need minutes, right? Because we read our question and we know that it's asking us per minute. So what we're going to do is to cancel these out, right? I know that I need the units to cancel out. So I'm going to put 1 hour over 60 minutes here because there's 60 minutes in an hour, right? And that's going to cancel out my hours here, but give me my minutes. And then I'm going to put to cancel out this liter and give me my mil. I'm going to put 1,000 mils over 1 liter. Now, when you go through and you cancel out the units that you don't need, right? We're going to cancel out the hours. We're going to cancel out the liters. We're going to cancel out the mils. So what we have left is 10 drips times 1 because we canceled out the liters times 1 because we canceled out the hours times 1,000 because we canceled out the mils. And on the bottom line, what we're left with is 1 because we canceled out the mils times 2 because we canceled out the hours times 60 minutes because we have not canceled out the minutes, right? Times 1 because we canceled out the liters. And what we're left with is 10,000 drips per 120 minutes, right? And then when we divide that, we're left again with our 83.33. But we know from asking ourselves what the question wants, they want it rounded to the nearest whole number. So we're left with 83 drips per minute, 83 drops per minute. And so it's really, you just plug it in and canceling things out and doing all of the good things, you know?
And see, both methods of this math problem are doing the same thing. It's just a
Mm-hmm.
matter of how your brain works. So If you are like myself and Courtney and you prefer the formula method, do the formula method. If your brain works in this more algebraic cancellation method, do the dimensional analysis. Like there's not a wrong way to do it. And if neither of those methods work for you and you have some weird voodoo way that you get there to the right answer, all that matters is can you get to the right answer every single time?
Right. Yeah, I 100% agree with that. Everybody's brain works so different. Like I said, I had to actually teach myself dimensional analysis for this. So I am a
And
formula
the thing
gal
is,
through and
is
through.
if you're checking MedMath with somebody else, this is a really, really important point. If you are checking MedMath with somebody else, you are not showing them your way of doing the math. You are doing the math, giving them your answer. They should also be doing the math and giving you their answer. And if those two answers don't match, you need to go back to the drawing board. It's not a matter of
Mhm.
that you show them your math and they look at your math and go, yep, that looks good. That is not a double check. Okay. A double check is I do math and I might do the dimensional analysis way. Courtney might do the proportion method. And then we come together if our math should both line up. And when that happens, that's when we're going to go ahead and we're going to say, yep, our answers match. We're good to go. This is now safe for me to do it. But I've seen nurses try to talk another nurse into their answer and be like, well, I carried this one here. I did this there. That's not safe medication administration. And really, what you should be
Right.
doing, if you guys are not coming to the same answer, you need to get another nurse and have them do the math too. And then you go, okay, where are we at here? Where do we have consensus where two of us have the same answer? That would be the correct answer.
Exactly. Because you should be getting the same answer, even though you're getting there different ways.
Like, so now we're going to talk about reconstituting medication. So maybe you're about to give a injection and you need to be able to, you have a powder that's in a vial and it's going to show up like this. So we have this example of amoxil or amoxicillin. So we're given an antibiotic and what it's going to tell us to do is you'll notice on here, you're going to see directions for mixing. So we want to tap the bottle until all powder flows freely. Add approximately 1/3 the total amount of water for reconstitution. Total is going to equal 78 milliliters. Shake vigorously to wet the powder. Add the remaining water. Again, shake vigorously. Each 5 mils will contain, or one will contain amoxicillin trihydrate equivalent to 125 milligrams of amoxicillin. So now we have our dosages right there. They give the usual adult dosage, usual child dosage. Okay. But the concentration that we see on this vial is 125 milligrams per 5 mLs. If we do a quick dosage calculation in our head, that means that each milliliter has 25 milligrams of powder that is dissolved. Now, the interesting thing is that it is reconstitution is what I like to call pharmacology wizardry. So notice here over on the left-hand side. So this we have 100 milliliters when reconstituted, but over on the left-hand side, how much fluid did we actually add to this? We added a total of 78 milliliters of fluid. Well, where does that extra 22 milliliters of fluid come from? And that is pharmacology wizardry.
I love it.
So,
It's the displacement of so when you go from like a solvent in a solute, right, and you make a solution, it is like magic. It's
yeah,
so cool.
consider me Walter White, okay? Because we're
Yeah.
doing chemistry over here, okay? So I take 78 milliliters of fluid and I put it into this and I shake it vigorously and wizardry happens. And all of a sudden, I have 100 milliliters of fluid. So, how much do I have total in here? If I have 25 milligrams every milliliter, right? Then
Mhm.
I can go ahead and I can take 25 milligrams and multiply that by 100, and that's going to give there's going to be 2,500 milligrams of amoxicillin in here. But my concentration gradient is 125 milligrams per 5 mLs or 25 milligrams per 1 ml. So now if I have a dosage where they say, hey, this adult needs to get a 250 milligram dosage every 8 hours. Now I can do a simple dosage calculation and I go, how much do they need? How many milliliters of fluid do they need to be infused every 8 hours? Now I can do that. So basically, if I know that I have 125 per 5, simple math is going to be, if I need 250, that means I need 10 milliliters of fluid is going to give me their dosage of 250 milligrams. Now, like I said, where students often get hung up and where they miss med math problems. So maybe I know that each dose for 8 hours is going to be 250 milligrams, which equals 10 milliliters of fluid. Maybe they'll ask, how much should they get in a 24-hour period of time? Okay. So if I'm giving it to them every 8 hours, that means that they're going to get a total of 3 doses, right? So I can go
Right.
3 times 250 is going to give me my total, which is going to be, what is that, 750?
Yeah.
750 milligrams in a 24-hour period of time.
Yeah.
Makes sense?
And I always like to tell people too, when they're looking at this, because I feel like a lot of students get hung up on this too, because they're like, how am I supposed to plug this in? You don't. Like, this is literally only useful in 2 situations. The first one is you are reconstituting it and you need to know how much is going to be left in this when it's reconstituted. Or if the question is asking you, what is the total dose in this entire bottle, right? Then you would need this. But other than that, if you're not getting asked those things or anything, like if you're not getting asked about anything regarding total dosage in the bottle, you don't care about it. Just ignore it. It is literally there only to tell you how much is in this bottle when you reconstitute it, and if they are asking full bottle specific questions. So
Yeah. Now
try
it,
not to get
it
too hung up on it.
Yeah, the thing is that you need to understand we're making a concentration when we make this,
Mhm.
right? So it's important that you add the correct amount of diluent for reconstitution. Okay. So we have to add the right amount of fluid. Otherwise, we end up with the wrong amount of fluid in
Mhm.
there, and then all of our calculations are wrong. So what will happen is that people will add the wrong amount, and then they are actually making a med error. And so like, say for example, say if I only added 50 milliliters of fluid to this, now I've added 28 milliliters too little, which means that I'm giving a more heavily concentrated amount of amoxicillin with every dose. In fact, I would have to go through and do a calculation to try to figure it out. And I don't think I can actually figure it out off the top of my head of how much they would be getting per ml for
Mhm.
that, because we've made a med error.
Right.
So you have to add the right amount of fluid to the vial. You have to add it the way that it says to add it. The only time that it doesn't matter as much is if you have a dosage of medicine that you're giving the entire vial in a dose, right? So if I'm mixing something up and it's a 4 milligrams per mil and I'm giving 4 milligrams and there's only 4 milligrams in that vial, then that's fine. You can add whatever volume you want. And if you give the whole thing, you may be diluting it down more or less than what it should be. But ultimately, the patient's getting the right amount of medication. But this is a vial that is made for more than one dose. This is an oral suspension vial that we're going to give to like a little kid with a ear infection or whatever. And so that is going to be stored in the fridge. After they're done, you notice it says refrigeration preferable but not required. We're going to discard this suspension after 14 days. All these instructions are on this. So this is where I'm going to be giving this kid repeat doses of medicine. So it needs to be the correct suspension. It needs to be the right reconstitution. Otherwise, they're not getting the right amount of medicine and they're going to develop a super infection, right? Because we didn't actually treat them
Mhm.
effectively.
And I do also just kind of want to add to that, just to be super, super clear. We're not telling you to just go if you're giving like a full dose and willy nilly mix it. Please always follow the directions on the
Correct.
vial. Like if it tells you to mix in a mil of fluid in like a solumedrol, that's fine. You are not able to just freely like nurse add fluid to a med, that does also have to be a doctor's order. What we're saying is that the math is going to math on that and it's still the same
Correct.
amount. But please
Correct.
always get permission to do that.
No, I'm purely talking about the med math side of it, not
Yeah.
about the best practice side of it. I'm saying that like ultimately your dosage is going to be correct even if you add a little too much or a little too little fluid. But most things that we're reconstituting are going to have a specific amount. And this is something where students always have their mind blown when they're like, okay, it said to add 2.2 mLs of fluid, and now there's 5 mLs of fluid. Like, where did that 3 mLs of fluid come from? And it is pharmacology wizardry. It's pretty
Displacement,
awesome.
baby.
It's science.
I love it. So what is it that Jesse says in Breakfast? Science, bitch.
I was just thinking.
Pretty sure that's what he said.
Yeah, science.
You
bitch.
should. And so now, kind of what we're getting into, and what Nick and I want to touch on, is solution concentration, right? So when you're looking at IV fluids and things like that, you have like your hypertonic solutions, your hypotonic solutions, your isotonic, right? We look at tonicity and things like that. And so with these, because we use each of these different types of fluids to treat different things, because it all has to do with like how water is moving around. But it's important to talk about what even is a solution, right? So when we were talking about reconstituting, right, we talked about our pharmacy wizardry with that displacement, right, of 78 mils mixed with this powder is now equaling 100 mils. So you have two different things. You have solutes, right, and you have solvents. So solutes are the particles, right, that are being dissolved. So what is mixed into the fluid? So, and then you have your solvents. So a solvent is a liquid that has the capacity to dissolve a solute, like to get really, really technical about it. So, but with a solute, right, here's kind of a tricky thing, right? So I'm going to start over. So it's important for us to talk about solutes and solvents, right? So a solute is a particle or a substance that is dissolved, okay? So if it can be dissolved, it can be a solute, but it's not a solute until it's dissolved. And what I mean by that is, think about like table salt, right? Salt, like sodium, has the potential to be a solute, but table salt in its physical form is not a solute until it's dissolved into something, and then the salt would become a solute, right? And that's why electrolytes dissolve in our blood and stuff like that, right? Because you have these particles that are dissolved in the liquid part of our vasculature, i.e. our blood. So a solvent is a liquid that has the power to dissolve, right? So mostly it's water, right? Water is our universal solvent. That's kind of like what's going to dissolve 99.99999% of the things in our body. But when you mix those two together, it becomes a solution. And that's where we have like hypertonic solutions, hypotonic solutions, isotonic solutions. So the fluids that you give through the IVs, right, are solutions. They're not solutes, they're not solvents, they're solutions. And we use these and we treat different things like dehydration, true dehydration, any type of electrolyte like imbalance through the process of like osmosis and diffusion. But those are two different things. So to do this, right, our body is going to use osmosis, which is the movement of water across the semi-permeable membrane, right, from a lower solute concentration. But then diffusion is the movement of the molecules, like the actual molecules, not the water, from an area of high concentration to an area of low concentration. Okay, so we have two different processes that kind of help like maintain homeostasis. And this is the whole idea behind giving these a really basic explanation of like us giving these fluids. And then you have things like osmolarity, right? That's something that we look at in healthcare. So that's going to be the amount of solute within a specified volume of liquid. So like having a high osmolarity means that there's a high level of solutes, and vice versa. But then we have something called tonicity. And this is an amazing concept. So it's how a solution affects water movement in and out of a cell, and how strong that process is. So this is where we use like the hypertonic, isotonic, hypotonic solutions. But our blood, our homeostatic blood levels are our isotonic tonicity. So that's what's really cool, is that we give these based off of the normal level of like blood tonicity. Is we'll give these fluids to like correct solutes and water levels and things like that. It's really, really neat. Because we hold water in kind of like 3 different places in our body. So you have your intracellular fluid that's in your cells. That's actually where most of our water is. It's something like 2/3 of the water in our body is actually in our cells. And it's a really low concentration of sodium, but a really high concentration of potassium in our cells. And then you have extracellular fluid, which is made up of 2 different things. So that's your interstitial fluid, which is kind of like that fluid surrounding the cells. It helps with like electrolyte balances and things like that. And then you have transcellular fluid, which is like your CSF, the fluid surrounding your lungs, the fluid surrounding your heart, that type of things, like your intravascular fluid. But all of these work together to maintain homeostasis. And so when we give these fluids based off of the tonicity of them, we can maneuver either water or solutes and things like that to correct homeostasis errors, which I just think is so cool.
It is definitely super cool because when we have all kinds of different disease processes going on or different things that are impacting that homeostasis, fluid is a big problem. Fluid shifts in the body in different disease processes. And that is a lot of what our job in nursing is doing, is treating those things through using the doctor's orders to give certain amounts of fluid in order to move fluid across a gradient. And it sounds very, very scientific, and it is, but we see this every day manifest in different ways. So, like in a patient with congestive heart failure, right? If they've got right-sided heart failure, they're going to have peripheral edema, and that fluid has shifted out of the cell and gone into what we call the third space. It is
Mm-hmm.
extravascular. And so we're constantly trying to diurese that patient and pull fluid back into the cell so that they can pee it off and get it out of their body so that their heart can be moving and utilized more optimally. So the tonicity of different fluids, I always think of it like a party. You end up, we've
Yes.
all been to that party where there is the right amount of people and everything is great. And that is an isotonic solution. Everything is perfect. You don't feel too crowded. You don't feel not crowded enough, right? And people are the solutes essentially, and they will move to where there is free space, or in this case, in this analogy, to where there's free water, right? Because they want to be able to have room to expand and contract as they need to. So, you're at that party and maybe you're all hanging out in the living room and it feels good. And all of a sudden too many people show up and you're like, I'm going to kind of vacate this area of the house. I'm going to go to the kitchen. I'm going to go to the dining room. I'm going to go out to the back patio. I'm going to disperse, right? Because we like to have that, we like to be isotonic, right? Sometimes it feels a little too hypertonic. We got too many solutes up in there and it's like, this is just uncomfortable.
Yeah. You're like
And then
bumping
maybe
into
it gets too
people.
uncomfortable and everybody starts to leave. And then all of a sudden the party becomes hypotonic, where we have less solutes. We have less people at the party because for whatever reason, people vacated,
Yeah.
and obviously in our body's processes, there's different reasons why that's happening, and it's not as simple, but I feel like it's a good visualization that everybody's kind of been in that position before, where you're like, okay, it either feels great, there's too many people or too few people, and one way or another, you want to correct it, and the body's the same way, is it's going to try to correct it and fix the problem because it doesn't want to be overwhelmed. It wants to be right at that point of equilibrium where everything feels nice,
Right.
and that is
And
homeostasis.
And I remember learning about this in nursing school. And one thing that stuck with me was registered nurse RN, who I love. Shout out to you. Oh my God, if you ever listen to this, love you. She uses this reference that I now teach my students, and it's that really kind of the main driver to this is salt, right? It's sodium. That's kind of like the big electrolyte that we use in our bodies. And so salt's kind of like the popular kid, right? And so water wants so bad to be popular. It wants so bad to be popular. Wherever salt goes, right, wherever sodium goes, water is going to inevitably follow. And that's important to note that, because then when you start getting into like diet recommendations for people with heart failure, right, for people who have issues with fluid overload, it's important to know and to kind of keep in the back of your mind, because you can help educate them, right, with their diet. That's why we tell people on a cardiac diet who have or on like kidney, like nephro specific diets, right? We really want to watch our electrolytes and our water intake, because having that overload of fluid on top of having an overload of sodium, right? It's just going to kind of wreak havoc, and we're not really going to be in a nice homeostatic environment in our bodies.
Yeah, absolutely. I think that's funny because I feel like that was the same basic analogy that I heard in
Hmm.
nursing school too, of the popular kid. So it's a great point to mention. Obviously, wherever salt goes, water follows.
Hmm.
So yeah, always following around the cool kid, even if it means killing your body, it's still trying to follow the cool kid.
Right.
Peer
Right.
pressure, man.
It's peer pressure, man. They don't give a shit about your your third spacing. It's just like,
Yeah,
now I'm
it's
gonna go hang
fine.
out with Salt.
It's fine. I'm just hanging out with the cool kid. It's no big deal. Who cares that you can't breathe?
Yeah. Sorry about it.
So it's interesting because, we talk about medication administration. We talk about all these different things that have to happen in order for us to give meds. We've got to have our rights of medication administration, right? There is 27 new rights to medication
Oof.
administration since I graduated nursing school. It used to just be 5 rights, and then it
Yeah.
turned to 6, and then you'll see some up to like 15.
Hmm.
But really, we come down to there are 6 rights that of medication administration that we must follow according to the NCLEX. So we've got right patient, right drug, right dose, right time, and right documentation,
Yeah.
and
Right.
right route.
Right
Yep, there you
route.
go. Route. I don't know about that. You say it however you want. So
I
we got to have
Depends
those.
on my mood.
Yeah, we have to have those rights of medication administration in order to do that, in order to be safe.
Hmm.
And when we talk about the med math side of it, we know that we can make critical errors that can be life and death for people. So there's some high risk medications that we need to know about. There's a whole list of them, actually, of high risk medications, but the ones that come to mind are potassium. Pretty much every facility has some kind of potassium protocol in place, right? Blood thinners are another big one, specifically clot busting medications. These are ones that we'll look at. Insulin is another high
Hmm.
risk medication. When I graduated nursing school, insulin was always a double sign off. It was no matter what, it didn't matter which route. There have been changes to that depending on facility specific protocols, right? So maybe you work long term care, and if it's sub Q, you're good to give that without a second sign off. I would just say, regardless of whatever the policy and procedure is at your facility, if you're giving large quantities of any of these medications, you should
Hmm.
be questioning them. So, potassium is always mixed. We do not give potassium IV push. We just do not. You give
And
it
it's
potassium,
never pushed. It's never pushed.
never pushed, because that's what we give for lethal injections
Yes.
is
Yes.
potassium. It will
Can I?
disrupt your electrolyte balance to the point of demise, right? So we have to be careful with these things. So if you're seeing a huge bolus of potassium, it should be a giant red flag. In fact, I was watching a creator talk about this. There was a small child that unfortunately passed because they were given 10 times the amount of potassium that they should have been given. And he was talking about how does this happen? How do nurses look past the red flag alerts and the things happening with this? And the reality is that there is a lot of alarm fatigue that happens. And I think that
Hmm.
that's a fantastic point. That absolutely does happen, to where you have so many alarms going off in a day, so many red flags popping up on your screen that it's easy to click past them. Think about your email account and the number of emails that you get throughout a day, how many are spam and how many are real. It is easy to miss a real email because of how much spam is out there. And the same thing is happening with alarms. In healthcare, we're getting spammed with alarms all the time. And so
Hmm.
this is a critical event. And oftentimes it takes a sentinel event like this to happen before health systems make changes. And unfortunately, a lot of times This just adds more monitoring instead of less. Instead of taking out things that are really non-critical, we add more critical things, which means you now are building more and more alarm fatigue.
Mhm.
So this is a tough challenge. If you're somebody who works in administration, who's working on these things, these sentinel events can be like, okay, we need to add something in order to make it to where this stands out more. But you can also make something stand out more that you probably already have it for potassium. And the way to make it stand out more is to make the less critical stuff stand out less, in my opinion. I think that that is a huge thing that contributes, is that we just get
Yeah.
so fatigued by how many times we see the, are you sure that you want to do this? We have a hard stop on every little thing. And now nothing feels like a hard stop. If everything's a hard stop, nothing is a hard stop. That's the problem.
Yeah. No, I would agree with that. And another thing I think that's important to know, and honestly, Nick, you like we do quite a bit of this in the ICU, but I feel like the level of this is different in an ED, is kind of those high risk medications being like weight based, like
Mm.
adding in that part of everything. Because I mean, in the ICU, we'll use like our pressors, right? Our weight based, our insulin drips, which is interesting that you said that about the insulin, because even in my experience traveling, what I noticed most was that for insulins was like regular insulin pushes, right? If you're correcting like a high potassium or whatever, regular insulin pushes and insulin drips were the only thing that required a dual signature. Everything else was kind of like fair game.
Yeah.
So I found that interesting, because I also remember during nursing school, like even giving 2 of Lispro, like you had to have another nurse sign off on it. So that's something that's actually changed. I mean, within the last
Well, and
decade, I feel like
we
there's been a
also have
pretty
the
big shift
convenience factor
on that.
of medications now too, right? Like, so insulin did not used to be something that was in a pen that was easily, you know,
Yes.
insulin pens are great because they make it easy, right? They make dosing really, really easy
Mhm.
and less prone for error. But like, if you calculate wrong of how much you need to give, you can easily go over. It's just an extra click or whatever,
Mhm.
and you're overdosing somebody. And so the question is the math behind it, is that happening like it ought to be? So
Yeah.
these are all things where, like, as events happen, as some problem happens, we go back to the drawing board and like, okay, is this what's best? You know, like, if every time that I draw up insulin out of a fridge, out of a multi-dose vial, I have a second set of eyes lay on it, because I just like, that's my own practice, right? That's how I feel good about that. I know that I'm giving the right amount. And, some nurses are out there giving stuff and like don't even know what a sugar is, just like, oh, well, it's scheduled insulin.
Which
Like,
is
it's
crazy to
just
me.
crazy, you know?
Because when I started and I was working in a long term, we didn't have any pens, like not even the Lantus pens. And I know we've talked about this, but like we just had vials and we had to like pull up our cloudy before clear insulin. Like you're giving you I want to go on record saying I have done the paralytics, right? I have done all the things. Like I have cared for some very, very, very sick patients. And the one medication that will make me stop and check 3, 4, 5 times is insulin. You can kill people very, very quickly with
Yeah,
insulin. Like,
absolutely.
and so I'm very careful. I'm very, very careful with my insulin too. So I don't blame you for that.
Well, and I think that, the problem where we end up getting in issues is when we do get too comfortable with stuff that we should not be super
Mhm.
comfortable with. It's something that we should be going, I need to just a little bit of a gut check, right? Like, we've talked
Mhm.
about that so many times, that like, listen to your gut, listen to like, what's your inner voice telling you to do here. And I think sometimes we just get in a hurry and we do stuff quickly, and, or whatever, or even in times when we have that double check happening with another nurse, we're both in a hurry. And it's like, yep, math looks good. I didn't actually go do a math
Mhm.
problem. Well, you should be doing a math problem. They should be doing a math problem. And I know it takes longer to do it that way, but that's the safe way to do it. And that's the idea of
Mhm.
that double check. And now we have virtual nurses. So, like, in all reality, like, those kind of things should actually be enhanced safety, because that is their job, is to do that double check. And it's cool with these cameras, they can see up to, actually
Dude,
look at your syringe
I
and see how close you
did
are.
that. I was cross trained into that department and you could literally, it was absolutely insane. You could scroll in from looking at the entire room to like the insulin syringe
Yeah, it's
or
awesome.
like even pupils. It was crazy. Anyway,
Yeah,
sorry.
it's
That kind of
great.
digressed a little bit, but I've done that, like verified insulin virtually.
Yeah, so another safety thing is pediatric medication dosing, right? So peds are
Mhm.
always weight-based doses. Anytime people are really sick, they should be getting weight-based dosing. It shouldn't just be this general, or if
Mhm.
you're doing very specific things, you're dosing Vanco, like it's fine if an initial dose for an adult, you're giving a 1 gram of Vanco, but that really should be getting titrated based off of how much they weigh. It should be,
Mhm.
we should be dosing accordingly to the body weight of the patient because if you're dosing a 150-pound person the same as you're dosing a 300-pound person, they probably need more. More of the
Yeah.
medication gets, absorbed in their tissues and whatever, and it can take longer to heal them. So we got to give them an appropriate size dose based on their body habitus. And when we're
Yeah.
doing peds, everything should be double checked, So this situation of this kiddo dying as a result of too much potassium, like, yes, there's system checks that should have happened, things that should have gone on. There's red flags that should have come up. And like I always tell my students, you do not want to be somebody that is involved with somebody's baby dying as a result of an error, right? And I say
Mhm.
baby loosely, I mean their child. Okay. And you don't want to be a part of
Yeah.
accidentally
Really
harming
anyone's
somebody of any
loved one,
age. Yeah,
honestly.
anybody's loved one. And that's the thing is we are always taking care of somebody else's loved one. Always. Every
Mhm.
day. You're always
Always.
taking care of somebody's son, somebody's daughter. You're always taking care of somebody's dad, somebody's mom. Like those relationships are important. Their life is important. And so it's worth our time to go and do things that matter and give it a little bit of extra time.
Mhm.
It's worth our time to check the math, make sure that everything adds up because at the end of the day, you want to be able to tell somebody that you did everything you could to save their loved one, right? I
Mhm.
love that line in Grey's Anatomy, right? We talk about Derek Shepard. It's a great day to save lives. He always talks about that, and I know it's a TV show, but it rings true, right?
Mhm.
We do CPR, we do all these things in front of other people so that we can say that we gave them every chance to live, that we gave them every chance to survive whatever horrible thing that they were going through in that day. And I don't want to be the person that is responsible because I didn't take a minute to do the math problem. I didn't double check the math. I didn't get with a nurse and do the discount double check. I want to make sure that I went through that time because that's what's ultimately going to save their life. That's what's ultimately going to create a good outcome is when we take that minute to do it. And you can list all the different reasons why you didn't because you were overworked, underpaid, underappreciated. You can say all of that stuff. But at the end of the day,
Mhm.
you're going to have to live with the fact that if you made that critical mistake, that's on you. And that's a hard place to be as a nurse. And I know a lot of people, after they make a mistake like that, even if they don't lose their license, even if they continue practicing, they have a hard time going back to work and being normal because there is that fatigue and that burden put on them of, oh my gosh, I just made a mistake that impacted another human's
Mhm.
life.
Exactly. But one thing I do want to point out though, just for those people who are listening is it does happen, right? And please don't be scared to self-report, guys. It's scary to think about taking accountability for that, right? And I could be speaking totally out of pocket here, but I don't feel like most places are like really, really punitive with making a med error, right?
It shouldn't be.
Most med errors in all reality, right, aren't going to lead to anything super, super crazy. Like in all reality, most med errors are not going to be, it's going to be like the one, honestly, that comes to mind was one that I had heard about from like a newer nurse. She had been a nurse for like 3 months or whatever, but she gave 20 of hydralazine instead of 10, right?
Sure.
In all reality, it actually did the patient a lot
It did the
better.
trick, right?
I
Lower
mean,
that BP.
lowered that BP to a very, very acceptable level. It wasn't even like low. I'll be the first person to say like I've made a med error, right? It happens, but I think placing the importance on self-reporting is something that I want to really encourage you guys to do just because it can be really scary, right? But we don't want to make a mistake and then hope things end up right. Like we want to make the doctor aware. We want to make our charge nurses aware, just because these are all eyes, like, that are going to be monitoring this patient if there's anything we can do to maybe like reverse it, you know. So
Yeah,
just make sure if this happens, take the accountability and tell someone about it, even if it's embarrassing, right? Because as someone who has worked pretty extensively as a charge nurse, like, I would rather you tell me and it be okay than you not tell me and the patient decomp.
definitely. Med errors are, it's a whole crazy thing to your psyche, right, as a nurse, because you wanna
Mhm.
do a good job. Like, I don't know any nurses out there. I don't care how nurse ratchet they are. I don't know any of them that are just, like, honestly trying to make mistakes. And if you are, I mean, you're weird and you have a problem and you need to get out.
Mhm.
Like, if you're trying to harm people, you need to get out.
Yeah, they
Um
make documentaries about that
Yeah,
too.
exactly. Don't
That's
be the
like,
next Netflix
don't be the
documentary.
next Netflix documentary.
No, exactly. Like, go find a way to release your aggression on,
Yeah,
something
play
else,
video
not people.
games. I don't
Yeah,
know.
go play video games. Exactly. Go
Go
play
play
Red Dead
video
Redemption.
games.
It's a great way,
Yeah.
you know, go be a cowboy in the West. You're fine. Anyway, medication errors, a lot of them are simple, right? And I would wager to bet that most people have made a med error and maybe not even realize that they made that med error. I think that that's probably way more common than the big whopper
Mhm.
medication error. But sometimes you have an in your face med error, and that feels really humbling. I'm going to tell you a story about a time when I made a medication error, and this medication error taught me so much. And so I'm just going to be candid about it. So I was in the ER. I was training at a new ER. I had worked in the ER for several years, and I think I'd been a nurse for 3 or 4 years as an ER nurse. And I went to a new ER, and I really liked this ER. I loved it. Things were going great. I had gone through day shift orientation, was going to nights. So I'm orienting to night shift. Like I said, I'm not a brand new nurse. I've been an ER nurse for a while, kind of know how ER or doctors operate and how things go. I
Mhm.
had this patient who was in hypertensive crisis. She's blood pressure's like 200 over 100s when she came in. Here was the thing: this lady was completely asymptomatic when she came in, and I'll never forget the way that it went down because uh, her story was kind of like the token old person who's concerned about every part of their health, even if they're not going to do anything about it. So before she went to bed, she had checked her BP and it was like 160s for systolic pressure. Well, she was
Mhm.
like, "Oh my gosh, it should be 130s. That's kind of where I live for my blood pressure." And she kept taking it. She took her blood pressure every 5 minutes and worked herself into a frenzy to where she made
Yikes.
herself go into a hypertensive crisis. Like, I don't think her blood pressure was actually that high to begin with. I think she was probably fine. She could have followed up with her doctor the
Yeah.
next day and been just fine.
I mean, I
But
got anxiety
instead,
too. I get it.
yeah, instead, the anxieties took over. She started panicking and really created this whole problem. So she comes in, she's worried about the blood pressure, and every time we would take the blood pressure, she would start verbally freaking out and her blood pressure would go up, And I'm like, well, we're not
Mhm.
going to just take it every 5 minutes. You're not having signs and symptoms of a stroke. So let's just chill. We'll see what the doctor orders. Well, so the doctor goes, yeah, let's give her, a dose of labetalol IV. So he orders up some IV labetalol. I give her the dose of IV labetalol and I kind of watch her over the course of an hour and her blood pressure really doesn't go down. But I am trying not to check her blood pressure too often because the more often I check, the more reactive she is. But I'm still going
Mhm.
like every 15 minutes. So I got busy doing something else and I hadn't pulled her vitals over in Epic, but they were still going off. And the doctor comes up to me and it's like 2 in the morning and he's about ready to go home. And he goes, "Hey, what's her blood pressure doing?" I'm like, "I'm not sure. I'll have to check Epic really quick and see where she's at." I check it. She really hasn't gone down much. And he goes, okay, well, let's go over there. He's like, I'm trying to go home. So he's like, I need to know if I'm going to admit her or what we're doing. So he goes over there, looks at her, and says, yeah, let's give her another dose of IV labetalol. And so he tells me to go grab it. He gives me a verbal order. So this is where the first part of this starts to fall apart is verbal order. So I'm like, hey, are you going to put that order in? And he goes, no, just go grab another dose of IV labetalol. We'll just do another 10
Yeah.
of labetalol. And I'm like, okay. So I go and I grab it, pull it out. It's a pre-filled syringe, and I grab it, and he goes, go ahead and give 10 of IV
Mhm.
labetalol. So I go and I give it. Well, he doesn't want me to go through my normal checks. He's just like, just go ahead and give it. I'm standing right here. You're standing right here. And so I didn't have an order, whatever. And this is my fault. I did not do my normal stuff. I was outside of outside of the normal range of what I normally would do, which would normally be tell me your name, date of birth, do you have any allergies to medication, all that stuff, going through all this stuff, scanning the patient, scanning the med. And in Epic, if you've overridden something, it will actually create an override where you can still scan against it. At least that's how it was in my facility.
Yeah.
Yours might differ. Um, but I didn't know that. I was new and I went ahead and I gave it. Well, all of a sudden the patient starts experiencing chest pain. She starts having PVCs on the monitor, like all this stuff is going
You're
on.
like,
Then
that's not supposed to happen.
she has couplets, like, and the provider looks at me and he goes, "What the heck did you just give her?" Well, I look down in my hand at the syringe and it is the same exact pre-filled syringe that I have used the time before from pharmacy, except this time instead of labetalol, it is lidocaine. So in the Omnicell, the wrong medication had gotten loaded by pharmacy
Oh,
into
shit.
so there's 50 vials of this stuff in there, and the
Yeah.
one that I pulled happened to be a lidocaine, and there was
Yes.
a labetalol in the lidocaine, and they were too close to each other in the Omnicell, and it was just a whole thing, right? So we end up going through this root cause analysis. Long and short, the patient's fine. We do an EKG. Obviously she's in a little bit of distress, but her blood pressure actually came down quite nice. She ends up getting admitted
Yeah.
to the hospital, and I have to own the fact that I just made this freaking med error, and I felt about this big. Like it was pretty life altering for me because I'm like, what the heck did I just do? I almost, I could have hurt this lady really bad.
Mm-hmm.
And the provider, he was kind of being a little bit of a jerk about the whole thing of like, give the med, right now, like you don't need an order, blah, 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 do a verbal order. Well, first off, I should have never taken that verbal order because we were not in a critical life threatening situation. That patient was fine. Second off, I didn't
Mm-hmm.
know the provider. I did not need to take that verbal order and it would have been fine. I could have said, can you please just put the order in really quick so I have something to scan against? This is for safety. I could have done all of those things. And then third off, I should have not deviated from my normal, which was to get her name, date of birth, scan the patient, scan the medication. Because if I'd done any of those steps, it would have come through and been okay. At the end of it all, we do a root cause analysis, and they interview me about this whole thing the health system does. Obviously, the patient was taken care of. I think they didn't charge her for her hospitalization because it was a med error problem of why she even ended up getting admitted. I literally almost quit that night, though. I felt so dumb. And so they do all these things. And what they came down with was they said, Nick, this is a Swiss cheese model event, right? So there
Mm-hmm.
is always going to be holes in our care, right? At different places, whether you're overstaffed, understaffed, never really overstaffed, right? Whether you're understaffed or whether you have too little resources in one way or another, you don't have enough to go around. Something like that is always going to happen. But usually, you are a slice of cheese with a hole in it, and there's another slice of cheese with a hole in it, but the holes usually don't line up. In this case,
Yeah.
they did, and it reached the patient, right? The issue reached the patient. We have barcode scanning, which is another layer to that. We have all these different things that we do to add safety. And in our
Yeah.
situation, they taught me about the Swiss cheese model, that sometimes the Swiss cheese holes do line up and something gets to the patient and causes a problem. In this case, we were lucky. It didn't turn into a sentinel event. It turned into an unneeded hospitalization. We fixed the patient, took care of the problem,
Mm-hmm.
but I felt about this big. And at the end of it, I learned a huge lesson, which was don't deviate from those normal things, right? So
Right.
medication errors can happen to all of us. We are all human. There is always that human error element to this, which is why we don't want to make shortcuts. We want to make sure we go through the process of doing things right, being concise, making sure that we're checking, crossing our T's, dotting our I's, getting a second set of eyes. All those
Yeah.
things matter.
But I
Doing our
think it's
med math
important.
right.
I think it's important to because I really want to emphasize what you just said about how we're all human, right? It is so incredibly easy to make a med error, which because I've made them too, right? Like I remember what mine was. I mean, I'll tell you guys my first one too, because I had just been a nurse for like maybe 2 months, and I was working in long term, which when you have 30 patients, it's very, very easy, right, to get into a habit and stuff like that. And I crushed 2 patients' pills at the same time, and I gave bed A, right, bed B's meds and vice versa.
Oh, no.
It doesn't feel good, man.
No.
It does not feel good. It really does make you feel like that little. And one of the which I didn't make this med error, but I was the charge nurse at this point in time and actually ended up having to talk this nurse into not quitting that night because they were like literally getting ready to call their boss and quit at like 3 a.m.
Mm-hmm. I felt that.
because yeah, because and it here's what made this one weird, and this was what really solidified it for me as like a wow, yes, you really need to scan. Like, is we had one patient who was on a ketamine drip, right, in one room, and we had another patient that was on a Narcan drip in another room. And at this specific hospital, they had kept um kind of like the patient specific medications that didn't need to be like refrigerated or anything like that in a labeled drawer, a locked labeled drawer, like outside the patient's room. And the meds had gotten switched when they were put in there. And I remember because it was such a good night. I was like, you know what? No shame in my game. I was sitting there like crocheting because it was like such a
It was
carefree
chill
night. It
till
was
you
so
gave that
chill.
Narcan to the patient
Well,
on
then
opiates.
the nurse comes up to me and she's like, "Hey, I need you." And I was like, "Yeah, what's up?" Like, da, da, da. And she goes, "I think I just hung this room's ketamine drip in so and so's room." And I went, "Uh-huh." And that was like one of those moments where like I walked in the room and I was like you stand outside the curtain and you're like taking a deep breath because you just know.
Yeah.
Cause like I checked everything, dude. Like I checked the Pyxis, I checked the freaking fridge, like the other patient's drawer.
Mm.
The patient ended up being fine, which is why now it's kind of just like more of a we can laugh about it and learn from it kind of moment was the whole night because that specific patient who was supposed to be on the Narcan drip was like in front of the nurse's station and she was just like laughing all night. And we were like, man, I wish we were where she is right now. She was there because she was on ketamine and she wasn't supposed to be. But this is like
You went
my
deep into
like
the K-hole.
yes, dude, it was crazy. And I remember like walking in and seeing that the ketamine drip was hung. And I remember asking the nurse, like, did you scan the bag? Because, that's one of the things that would pop up, big red flag. And she was like, well, I scanned the old bag. Like she took
Oh,
the old Narcan bag off, right? And didn't scan the bag that you were hanging. So big educational point. Please always scan the bag that you are hanging. But I remember like, I was like, man, listen, we got to tell the doc, and the doc came, pharmacy came, and it was all three of us kind of looking up on up to date, like calculating the safe range for this medication, right? To make sure, that she hadn't received too much. And thankfully the patient hadn't, like she was honestly just having a really good time. And I remember going in with the doc to tell this patient that they had received ketamine instead of Narcan. And the patient was like, oh, that's fine. And we were like, okay, well, it's fine right now
yeah.
because you've got ketamine, but like, we'll tell you again in the morning, you
Yeah.
know? But I remember like that debrief with that nurse, man, she felt so bad. And I remember being like, dude, it happens. Like the
It
patient's
does.
okay. Thank you for self-reporting. Right. And, like that's not a moment to shame anyone. So
No, but
it
here's the
happens,
thing.
man.
When you make a med error, when those things happen in the moment, you're going to feel super, super small. And you're going to
Mm-hmm.
feel hurt by the fact that you messed up. You're going to feel less than. Like, in nursing in general, like if we mess stuff up, I just think we take it really hard because we want to do right by our patients. But the thing is I always think about this, that one of my friends, when he was in high school, he got E. coli from going to Jack in the Box. Okay. And he won a
Okay.
big lawsuit with Jack in the Box. They paid him out a whole bunch of money, paid him and his dad out, but they both were in the hospital for a long time with this E. coli infection.
Yeah.
And I will never forget him talking about how he was going to Jack in the Box. And I'm like, are you kidding me, dude? Like, you're going to go to Jack in the Box after that? And what he said is, he goes, dude, after an E. coli outbreak and it being all over the news and them paying out millions of dollars to people. He's like, Jack in the Box is the safest place to get a burger, man. Like,
Yeah, now it is.
like at that time, like, and this is many years ago, but the thing is like, it's true too when it comes to medication administration. Like, if you make an error, you might think, well, I messed up and people think that I'm dumb, but you are not going to make that same error again. You might make a
Mm-mm.
different error, but you're going to probably be the safest nurse when it comes to a standpoint of medication administration, because now all of a sudden you have unleashed what I call the pucker factor.
Mm-hmm.
What other people will glaze over, you're not going to glaze over, which is what is going to make you a solid nurse. It's going to make you rock solid in your clinical judgment, because now you're like, I have tasted and seen how bad it can be. I have
Yep.
made problems happen, and now I'm not going to go down that road again. I'm going to make sure that my safety is above and beyond. And I wish that there was a way to get people to just understand the severity of what we do without them experiencing the pain of going through the med error. But for some of us, we don't experience it that way until it's us, right?
Right.
Some of us have to go through the school of hard knocks. And this is one of those hard knocks, right? You take it and it's done, and now you're better for it. So I would say that making a med error doesn't disqualify you from being a great nurse. In fact, I think it tempers you and makes you able to be a great nurse because you've gone through some stuff. And it also opens up your eyes to have compassion and empathy for your
Mm-hmm.
fellow nurses when they make those errors. So if you're a seasoned nurse out there and you've got that new grad, remember what it was like to go through the fire and have that happen when you made the error, and be candid about it. Tell people about your experiences. Maybe somebody can learn from just your experiences, but more than likely they're going to end up going through their own. So if you're the new nurse and you end up going through your own, you're not bad for going through it, but you better learn from it. Don't do it again. Figure it
Mm-hmm.
out. And I hope that it's not something that results in problems to your license. I hope that it's something you can just grow and change from. And I do believe that self-reporting should just be such a paramount thing that we just do it. When I make the error that maybe I didn't notice right away, we still report it so that we can acknowledge, like, hey, I'm going to get better because of this. And
Yeah.
it should not be a punitive thing. I think that it is important that we do self-identify when we have problems so that we can be better.
And honestly, just prevention in general. That's why
Yes.
we're so open about telling you about our mistakes and how much it sucks, because hopefully it will kind of inspire you to just not skip those types of like safety steps and things like that.
And when you find that nurse that's ultra safe, there's probably a story behind that. There's probably a
Mhm.
reason why they are acting the way that they're acting. The ultra safety comes out of a point of, I'm not going to mess this up again. I'm going to do
Mhm.
it right. And so that my patients are safe and so that I keep my license safe.
Yeah.
Because there is worse things than just getting fired from a job. Getting fired from a job is fine. It happens. Not that I want you to get fired, but I would rather you get fired and have your license intact than lose your license and then your
Yeah.
moneymaker is gone. Well, hey, everybody, thank you so much for joining us again on this episode of Crashcart Nursing today. I hope you learned something. Remember to like, subscribe, and share. Give us a follow. If you haven't already, tell a friend about it. We'll have some cool stuff coming up in the next couple of weeks, hopefully some giveaways and things like that. So make sure you follow on social media. We're on TikTok, we're on Facebook, we're on YouTube. So follow us there, check us out. We're on Spotify, hopefully soon coming to Pandora and the Apple Store as well. Anyway, have a great week, everybody. Talk to you soon.
Okay, thanks guys.
Be strong when you feel like giving up on everything and everyone around you.